Okay, so for week one of Nursing 230, we're going to be going over acid-base balance, acid-base imbalance, some of the conditions that can cause it, some of the consequences of changes in your pH and changes in your ABGs. One of the first things I have here is actually a link to a video. This is going to be a video from Nurse Sarah. It's going to be giving you some different methods of being able to read the ABGs. One of the methods they call like the Rome method and the tic-tac-toe method. Whatever is more comfortable for you is whatever is going to be best for you. If other people do it a certain way, don't feel forced to follow it. Just do whatever is comfortable, just kind of like the math. Some people do the formula, some people do the metro analysis. It's whatever works for you. Okay. And then to review some of the values that you're going to want to know, you're going to want to have the pH level memorized because you're going to be needing to interpret these things and are not going to provide normal values for these labs. So an ABG is an arterial blood gas, so that is something that they will obtain using blood from an arterial line or just from a single time stick. So the values you're going to want to know is the pH the normal pH of a human blood is 7.35 to 7.45. The lower the number, the more acidic. The higher the number, the more basic, the more alkaline. Okay. Um, the next thing you're going to want to look at here is the CO2, the partial CO2 level. So the normal value is going to be between 35 and 45. And the way you want to think about it is, when you're breathing in oxygen, breathing out carbon dioxide. So you kind of associate that with the lungs. So this is going to be a value that you're going to be used to kind of represent your respiratory system. Um, and your CO2 is also, carbon dioxide is also an acid, has acidic properties to it. So higher number of CO2, the more acidic something is. And we'll talk more about the representation of respiratory, what that means when we kind of go into interpretation. The next one is going to be your bicarbonate. That's your HCO3. This is going to be between 22 to 26, although these numbers are going to vary between hospitals and all that kind of stuff. Your bicarbonate, that is a buffer. Your body uses that as a buffer to essentially help with your acid imbalance. So if your body has too much acidity, the buffer helps to keep your levels more managed in your body because your body is meant to function at a specific pH, specific acidity, and your cells do not work as well when you're off. So your body will do its best to contain it and do its best to keep yourself within normal ranges. Your bicarbonate is considered basic, more alkaline. A higher number of bicarb is considered more basic. And then another value you get from your ABGs is your PO2, and this is different from your SATO2. So the normal values for this is going to be 80 to 100. But for interpretation, you're just going to focus on these three values here. The bicarbonate is considered representative of metabolic, which you want to start associating that with the kidneys because the kidneys do certain things like waste potassium, waste magnesium, um, electrolytes. It helps to waste or retain bicarbonate in order to help control your acid-base balance. So your lungs, um, your your kidneys help to regulate. And then another organ that helps with acid-base balance is also your liver. Your sorry, your pancreas. Your pancreas is helps create bicarbonate. So with malfunctioning pancreas, you're also going to be struggling a bit to you're going to be struggling to be able to buffer and decrease this, manage the acidity, just due to the fact that you're not making enough. And we'll talk more in detail about that later. Okay. Um, for me, the way I kind of do my things here is anything that's in like this cyan kind of blue-green color is like additional information that you don't really have to know in the immediate, but might be helpful down the line, either in a future Kaplan exam or in a future class or on the job. And anything that's going to be highlighted in yellow is going to be more immediately important for the class and for understanding the concepts. Okay. So this right here is the anion gap. This is something that you will go into a lot more detail next semester when they go over DKA, diabetic ketoacidosis. But it's just something that was put down as a topic of discussion in your SLO slash all those objectives. So I'm going to mention them now. That way you have a better idea down the line of kind of what this is referring to. You guys might have had a patient with uh, anion gaps that are measured through their labs. You might have seen that. Um, you might have seen that with somebody that has sepsis, um, and therefore has lactic acidosis. Somebody that has, DK, um, and then we'll kind of go from there. So, and the anion gap, if it's not being measured through a serum, is going to be calculated by a formula. So the anion gap is equal to your sodium levels subtracted uh, by the summation of your chloride number alongside your bicarbonate. And these are all serum values. So that is worth noting because something that you might see on some labs is that uh, your serum bicarbonate might be listed as CO2, as a serum CO2 on a complete metabolic panel, as opposed to looking like this, it will look like this instead. And those are the same. Those are the same. They're just different states because the CO2, when it bonds to a hydrogen, um, essentially they kind of exist in certain ways. So like the bicarbonate, once it's used, kind of done its thing, will show up as CO2. So in terms of like serum labs, you might see a serum CO2, and that will be the same thing. You'll see that the regular range will be roughly this. So you're not going off the ABG bicarb, you're going off the serum one, okay? Depending on the hospital, it will show up as HCO3 on the lab, or it might show up as CO2, okay? So the purpose of an anion gap, so anion is something that is a negative charge. It's referring to the charges of the electrolytes and other things in the body, such as acids. So it's used to kind of determine if there exists any anions, any negatively charged things. Don't worry too much about the charged things, but this is kind of for context. Anything that is not able to be measured through or is not currently being measured through labs, because you can specifically measure lactic acid levels, or something that is done all the time for patients in sepsis or patients going through shock, or ketones, which is something that can be measured for someone that has DKA. But this is a way that you can measure using your basic panel to kind of determine that there's something off and you need to investigate more, or the doctor has to investigate more, or you should pace the doctor to investigate more. Um, so the idea is that when this value is off, it's showing you that there is a presence of either lactate, ketones, toxins, quote unquote. And when this anion gap is high, This is showing that there is presence of DKA or lactic acidosis. So lactic acidosis meaning acidity in the blood caused by a buildup of lactic acid, which if you guys ever went over, the Krebs cycle, um, if we don't have oxygen to finish the cycle, then our body goes into um, anaerobic respiration, makes lactic acid as a base. So if somebody is in shock, they don't have enough blood to circulate to provide oxygen throughout the body, then your body starts producing lactic acid as a byproduct. So someone that's in shock, someone that is just not being able to properly manage their the acid balance properly due to organ failure will have a buildup of lactic acid. Or somebody that is unable to control their sugar levels, unable to manage their insulin, such as a type 1 diabetic, will have a buildup of ketones, which are negatively charged and therefore will represent itself by having a high anion gap. So, like I mentioned before, the bicarbonate is a buffer against the acid, meaning that it will be effectively, quote unquote, used up in order to neutralize the acid to try to keep that level more towards your baseline because your body at some point becomes incompatible with life because your cells will not work properly, proteins will not fold properly at certain pH levels. So your body does struggle or does make that struggle to balance itself out. The body does that in general, like we know with vital signs, it will compensate for a low blood pressure with a high heart rate and a high respiration, and vice versa. Another one of your labs that is involved with acid-base balance is your chloride. So your serum chloride. Your chloride is also a way that adjusts itself. And we can kind of see that here with the formula because you notice that the chloride is included in this formula here. And it's there to uh, kind of be like a second line of defense almost when is already um, your bicarbonate is being used up and you need to rebalance your acid base. It will adjust itself. So you'll have an increase of chloride when your body is actively trying to balance its acid base. And there's a lot more nuance and a lot more detail that goes onto it, but this is something that we'll discuss when you guys are specifically going over DKA, okay? But the general idea is that there is such thing as a acidosis. So not every acidosis will have a high anion gap, and the reason for that is because of just the sheer presence of lactate and ketones will kind of like this paragraph says here, if you have that buildup of lactate and ketones, your chloride, which you can see is negatively charged, does not need to increase to kind of make up for that difference. So examples of something where the anion gap will be normal would be like a respiratory acidosis. So like a COPD patient, because the reason they're acidotic is because of the higher levels of CO2, rather than because of uh, buildup of lactates and ketones that are causing the formula to be changed. So the bottom line is an ion gap, useful for determining if or kind of making the observation that there is a buildup of lactic acid or possible DKA. But it will not be high for every case of acidosis, such as a respiratory acidosis caused by somebody that has COPD and is unable to get out all the carbon dioxide um, out of their body. It is also possible to become acidotic due to too much chloride, because like I mentioned here, the chloride is negatively charged. So there is such thing as a hyperchloremic metabolic acidosis, which is something that can occur when somebody is receiving high amounts of normal saline for long periods of time. So for that reason, you will have some doctors that do not like to provide maintenance fluids. If the patient can drink water, why do they need normal saline? You're increasing the risk of um, this hyperchloremic acidosis when they can just drink water themselves or just be encouraged to drink water. So that's kind of like a hot debate between doctors, I suppose. I guess the nephrologists tend to be more sensitive to that, and some doctors just like having maintenance fluids, but that's kind of the general idea there. But like I said, here it's just extra information and it will kind of provide a little bit more context in the situations where you have a patient that um, is recovering from, because you guys probably won't get, like I said, third semester, you guys might actually be placed on a step down floor, like a DOU. So you might actually have patients where you're monitoring um, the anion gap because maybe they're recovering from septic shock, or maybe they're recovering from a DKA, so they're on a step down unit because they're more stable, but you're still uh, looking at um, looking at the anion gap, so you have a better understanding of what's it's measuring and what's kind of going on. If the serum values for the anion gap is not automatically calculated by whatever hospital's labs is being drawn. The formula is here in case you want to calculate it yourself. Okay. Another thing that could be a cause for concern when it comes to acid-base balance includes your thyroid labs. So um, the difference between hyperthyroidism and hypothyroidism and how they can affect your acid-base balance. And this is caused by either metabolic or respiratory. So looking at hyperthyroidism, you guys learned about hypothyroidism last semester, I believe. Is that correct? Last semester you guys learned about hypothyroidism?
Yes, we did.
All right, perfect. So with hyperthyroidism, you want to think about that everything is increasing. You're more jittery, you're sweating more, you're breathing more, blood pressure might be a little bit more increased, heart rate is beating faster, bowels are moving faster, um, your body's warmer, you're less tolerating heat, because your body's already warm. So if you are uh, unmanaged, but not to a severe extent to the point where somebody is having a thyroid storm, an increase in respirations will lead to you breathing out more carbon dioxide than what would be normal because you still want some carbon dioxide in your body to maintain normal levels of your blood pH, in which case you then go into respiratory alkalosis. So a basic, your body, your pH is more basic due to a respiratory cause. So respiratory alkalosis. If you are, your bowels are, bowel motility is faster. You're getting rid of waste faster, di or having diarrhea, losing electrolytes, losing bicarbonate from excessive diarrhea, or just losing stuff, sweating out things, um, all that stuff. You can go metabolic alkalosis because you are losing some of the acid that your body has because you're getting rid of it too quickly. When you go into a full-on thyroid storm, your body is now burning things faster than it than it needs to. Your body's oxygen demand is a lot higher. Your body in general, right? Someone that's in hyperthyroidism, one of like the basic things on like a lower scale is that they need to eat more, they need more calories because they're burning calories so much faster. So somebody that is having a really bad episode, very uncontrolled, needs more energy, needs more oxygen. So at some point, the demand is too high for the supply. So kind of like we talked about, when your body doesn't get enough oxygen, you're going to start having anaerobic respirations. So that's when your body starts going into metabolic acidosis due to the buildup of lactic acid, and then that's something that again we can kind of relate back to the anion gap. um, because of that buildup of lactic acid. So these are just some examples there. Hypothyroidism. Um, if it's very unmanaged, the thing about it is that hypothyroidism is easier to manage than hyperthyroidism is. It's less critical in terms of acuity. Um, I guess you could say kind of similar to how potassium is like increases or decreases in potassium are going to be more high priority than like a minor change in sodium levels. So it's kind of like that relationship where you of course want to manage it, but the acuity of it, the risk of sudden crashing is a lot lower with hypothyroidism, but the idea is still there, just in the opposite direction. So now if your body's metabolism is slow, you're going to have slower respiration, slower heart rate, lower blood pressure, lower GI motility. In this case, you can have decreased respirations, and this is like if it's very unmanaged. Um, Having the opposite problem as hyperthyroidism, so instead of respiratory alkalosis, respiratory acidosis, because you're not breathing out enough carbon dioxide. And then the extreme form of hypothyroidism, myxedema, coma, it ends up also leading to metabolic acidosis, just for a different reason. In this case, now the body is going too slow and not perfusing well enough. So both for not enough flow, your body is then lacking oxygen and lactic acid builds up. So those are examples of how you can have acid imbalance due to thyroid issues, acid-base imbalance due to diabetic ketoacidosis. Lactic acidosis can also come from shock and certain organ damage, including liver damage, pancreatic damage, kidney issues. But we'll talk more about that um, here with the overview. Is there any questions on anything so far or anything that you want clarification on? Okay, so we'll kind of move on to the overview. So as I mentioned before here, the whole system of acid-base balance is handled by your respiratory system as well as regulated by the kidneys, but there's also um, efforts being made by the liver and the pancreas. And then the way that your body compensates, because your body's always compensating for things, regulating itself, is that your body, your lungs will compensate by changing how you're ventilating, either ventilating really fast or ventilating slower. So when it comes to compensation by the lungs, so let's say somebody starts hyperventilating. Um, you can think of it like when somebody has acidosis, metabolic acidosis, they will have Kussmaul respirations. So that's that fast, shallow respirations. The idea being that you're trying to get rid of excess um, acidity by getting rid of more carbon dioxide to try to make up for it. And your body compensates using both systems, but the lungs, typically the way it goes, your body will compensate with both, but whatever issue you're having, the opposite system will be the main thing trying to compensate. So in that case, like I said, metabolic acidosis due to DKA, diabetic ketoacidosis, it's being compensated by the lungs in this case through Kussmaul respirations. But your system, your body will compensate by using both ways. And one of the things about the compensation here is that respiratory compensation is going to be more of a fast acting band-aid, less effective over long periods of time, but it's faster acting. Okay, so it's like a little band-aid. It's kind of like a crashing patient getting a bolus. It's a band-aid. It's not the fix. It's just something that's gonna tide them over for the meantime. while metabolic compensation is being managed mainly by the kidneys, and that is through the process of either getting rid of bicarbonate and hydrogen um, cations, which is the acid, you can say, or retaining that bicarbonate or retaining those positive that acid. Um, and this metabolic pathway of compensation is a lot slower, but it is more effective in the long term because it's making relevant, larger scale changes in the body as opposed to the kind of like the band-aid that's being done by the lungs. Some of the ways that the liver and the pancreas contribute is that the liver is also your liver is there for metabolism. It's going to metabolize medications. It's going to metabolize whatever you're ingesting, like alcohol and drugs, but it's also going to be managing your lactic acid breakdown. So if your liver is not functioning very well, it's going to have a harder time breaking down lactic acid, and you're more likely to have um, metabolic acidosis if your liver is shot. Your pancreas is also help contributing because it's producing the bicarbonate. So somebody that is um, having issues with their pancreas, pancreatitis, whether chronic or acute, might be having acid-base imbalance, metabolic acidosis, due to the lack of bicarbonate in the body. So these are some things to keep in mind. So respiratory, the lungs will help to manage that by changing how your breathing is, and then your organs will do a slower but more effective management, and you will see how that is affected by different conditions. So now going over each specific thing, respiratory acidosis. So some of the possible causes of respiratory acidosis include things such as COPD, respiratory depression, acute respiratory failure, ARDS, which you will learn about later in fourth semester. Certain conditions like maybe multiple sclerosis, ALS that makes it difficult for the body to control its own breathing, control the muscles that control the breathing, asthma, chest trauma, drug overdose. So Luna asks, what about those whose pancreas is removed? How will the compensation system work for them? So for those type of patients, your body has um, other ways to compensate. You can see here like the kidneys work with it, the liver helps to break down lactic acid, but um, these type of people will also have changes to how their diet is, the how they take care of themselves. I would have to do a little bit more research on this very, very, very specifics. Let me see. Supplementation. So supplementation and just kind of working with the other systems, so the lungs, the kidney, and the liver, will be the primary things there. People with pancreatitis, or I guess in this case they don't have a pancreas, they will take they will take the enzymes rather, to help digest, and then they can get supplementation to kind of make up for all of that. But at least in terms of this class, you don't have to worry about it in terms of getting asked about any of like the super deep cut. You're going to be tested on acid-base balance again in fourth semester, but it's going to be a little bit more basic, or a little bit, this class will be a little bit more basic. Okay. So then we can go over some of the treatments here. So it would involve treating the underlying condition. So if somebody's having an asthma attack, you're going to give them their rescue inhaler, their bronchodilators, their albuterol. If somebody's having a drug overdose, such as a opioid overdose, that's what Narcan is for. Inflammatory process, in this case, that would be something like a COPD, which like acute chronic bronchitis, you have inflammatory process there. ARDS is an inflammatory process. Steroids help with asthma as well because you have constriction of the airway. So steroids, albuterol. If it gets to a point where they need help to breathe, mechanical ventilation. And another way that this can be treated is also just treating the consequences. So one of the things that can be a consequence of acidosis in general is hyperkalemia, so high amounts of potassium in the blood. And this is the patho reason. So the idea is you have this buildup of H plus, and your cells take those take that influx in, which causes the potassium to leave, leading to a high potassium in the blood, levels in the blood, which can lead to other issues such as heart conditions. So this is, they always say like the core, your heart and lungs are always deeply tied together. They affect each other in a lot of different ways. Makes sense. The whole system is tied together. Your body's compensation is tied together between heart rate and respirations and everything like that. If the patient's not getting enough O2, then you're going to provide oxygen support. Just keeping in mind that those with COPD, their regular range can be between 88 to 92, but it does depend on the person. There are people with COPD that their baseline without receiving any oxygen, they can be without oxygen, and their baseline is could be 90, 93 to 95. It's just kind of determining where that baseline is. Um, but it's keeping in mind if this is a brand new patient, all you know is they have COPD, they look stable for their baseline and they're at 88 to 92, that's normal for them. And then other things that we learned about when it came to learning about asthma, COPD, pursed lip breathing, like blowing out a candle, turn cough and deep breathe, especially after waking up, because they can have a buildup of secretions that might give them more chest congestion, lower O2 levels when they first wake up, and hyperventilation to try to get rid of some of that carbon dioxide, which you want to encourage for the COPD people because they have overinflated lungs, which leads to more pressure in the chest. It can lead to that whole pulmonary hypertension, which can then affect the heart. Pulmonary hypertension could cause heart failure, right-sided heart failure. People with COPD are at a higher risk of right-sided heart failure. They're at a higher risk of pneumothorax, spontaneous pneumothorax. So all these things to kind of keep in mind. Um, but yeah, kind of like we said before, though, the lung compensation with the lungs is going to be fast acting. So you see a lot of the treatments for the acidosis, regardless of which kind it is, will include managing your respiration. So respiratory acidosis, they're encouraged to hyperventilate to try to get rid of that CO2. Okay. Um, okay. Any questions on this so far? Okay, give me 1 second. I will make adjustment just so that we can make this a little bit more interactive. So I will cover up some of the stuff that's written down so that we can kind of have some of you guys kind of be able to kind of spring it out from your own brains. So, but you got kind of the idea of what we're kind of discussing here. So then we can do that with respiratory alkalosis. So give me 1 second. But the next one we're going to talk about is respiratory alkalosis. Could you guys put down in the chat what are some things that you think could be causes of respiratory alkalosis? Just make sure that it's not. Yeah, so give me some ideas of things that you think could be causes of respiratory alkalosis. Okay, so we mentioned anxiety, hyperventilation. Yeah, for sure. Fever, sure. If like, yeah, basically anything in this case, again, it's respiratory based. So this would be hyperventilation, anything that can cause hyperventilation. Um, this is like a interesting, tricky, you could say a tricky one. When somebody's having an asthma attack, what is their expected progression when it comes to acid-base balance? Someone that's having an active asthma attack. So someone is just chilling and then they're feeling more constricted and they're struggling to breathe. How would you expect their acid base to kind of be going at that front? Like what are they doing at the time? What do you expect? What do you expect in the short term? What do you expect in the longer term? Yes, so they're gonna be in the generally moderate to longer term, they're going to be respiratory acidosis because they're not able to get oxygen in due to the inflammation. There could be wheezing. They might not be able to kind of get that exchange going. They're going to have CO2 being trapped in the lungs. So that would lead to respiratory acidosis. Um, one of the interesting, but it makes sense once you think about it, is that at the very immediate, and I do mean very like pretty immediate short term, they will initially be in respiratory alkalosis because in an attempts to compensate for the compressed, constricted airway, they're going to be hyperventilating. So in the very initial, very immediate, they will be technically in alkalosis before the compensation can no longer compensate, and then they go into acidosis like what we would expect. But again, that is in the very short term. And then when it comes to ABGs, if somebody is having an asthma attack, you're not gonna take an ABG and then wait for that to come out. You're gonna treat it, and if they're having a longer lasting, by the time you get an ABG done on someone that is having something like that happen, you're not gonna see alkalosis because by then they should have been treated, or they're already having like the long-term consequences of it. But it's just like an interesting thing to see in the in like how the progression is. So they're going to be initially hyperventilating to compensate for the constriction, which technically puts them in alkalosis, but because the end result is trapped CO2 in the lungs, inability to get enough oxygen, a buildup of CO2, they're going to be acidotic in the longer term. But that is an interesting thing. I mentioned that just because I figured Mr. Robbins might have made that mention. He has done that he did that for our class. Like, I guess I graduated what over two. I guess it's been almost 2 years now. Oh, like a year, a little bit over a year. But the whole curriculum, that's something he mentioned. I then wanted to make sure nobody was confused on that front. So yeah, you guys had the overall right idea there. And then what are some ways that if somebody is having, you know, respiratory alkalosis, they're having that anxiety, the pain, the fever, infection that's causing them to hyperventilate, what are some ways we can try to treat that, either long or short term? Just anything that comes to mind. Sure. So we're gonna help them slow down their breathing. Have you guys ever seen in like the movies where they have them breathe into a brown bag? Like someone's having anxiety attack and they bust out like this the brown paper bag and they breathe in. Do you think that's something that would be a that could be done for somebody like this? Do you think it's something that can actually be done or no? Or at least in terms of like anxiety, at least. You say yes and no. Do you mean like yes, you've seen it, and no, you don't think it would be something to do, or like what do you mean by that? So in the scenario where somebody is having an anxiety attack, they are hyperventilating, but not because they're lacking, not because they're necessarily missing oxygen. The hyperventilation is a cause of the anxiety, is the caused by the anxiety. When you breathe back through the bag, you're breathing back carbon dioxide. But if you recall, the whole process of acid-base balance is primarily focused on carbon dioxide and bicarbonate. The O2 is something you want to monitor, but at the end of the day, the acid balance is affected by the bicarb. So in the scenario where somebody is hyperventilating due to like anxiety, panic attack, having them breathe back the CO2 is actually wanted. You actually want to do that because you want to get them out of alkalosis. You want them to, you don't want to do it for a long period of time, but the idea is that you want to get some of that CO2 back to get the pH value back into where it's supposed to be. So in this case, actually breathing into the bag for an anxiety attack is indicated as long as they're not hypoxic. Because again, in the situation where someone's having purely just an anxiety attack, panic attack, they're not missing oxygen. They're they're hyperventilating due to anxiety, and they're actually just getting too much they're getting sorry, they're getting rid of too much carbon dioxide. So we do want some of that to be breathed back in. Does that make sense? I know it kind of sounds kind of weird because CO2 is like a waste product and stuff, but we do want some of it in the body. It's still there as a form of managing the acid base. So in this case, as long as they're not hypoxic, as long as their O2 is normal. So this is kind of like where we kind of mentioned, like if someone is hyperventilating, right? Are they having an anxiety attack or are they having an asthma attack, right? They're both going to present similarly. The person that is having an asthma attack does not need to be breathing back the CO2 through a brown bag because the problem is they're not getting enough oxygen and therefore they need, even though they're going to be technically hyperventilating and technically initially, in the very initial, being in alkalosis, the person with an asthma attack is moving towards respiratory acidosis, and therefore they're going to want this treatment plan here, right? They're not going to want this because they might be hypoxic. While someone that's having an anxiety attack, they're not having oxygen issues. So in that scenario, breathing back the carbon dioxide would be indicated instead. Does that make sense? Okay. Let me know in the comments if anyone's still confused, if anyone is confused or wants more clarification. So the overall is if somebody is having an anxiety attack, they are not lacking oxygen, but they're breathing too much and therefore getting rid of too much carbon dioxide. So breathing through the paper bag would be appropriate versus someone that's hyperventilating because of an asthma attack. And technically, they are starting at alkalosis, but they will quickly shift to acidosis due to being hypoxic. And therefore, you want to treat it immediately with the inhaler. Okay. Next up, we have metabolic acidosis. So here I have some blanks. What are some potential causes of metabolic acidosis that you can think of? I do have it split between gain of acid and loss of base, but you can just sound off whatever and we'll put it all in the right spot later. So anything that we talked about a few already. Anything that you guys can think of. So DKA is going to be one of them. So uh, diarrhea, lactic acidosis. So yeah, so things we talked about, sepsis, yes. So we mentioned lactic acidosis. So what else might cause lactic acidosis? What other organs failing could cause lactic acidosis? Renal failure, yes, because that's we talked about how the metabolic is managed by the kidneys primarily. So if your kidneys aren't working, then you're not going to have proper regulation. What other organs did we discuss that could be relevant? What other conditions did we discuss up above? Pancreas, yeah. So if your pancreas isn't working as well, you could have some mild metabolic acidosis. Liver, so liver, yes, correct. So if you have liver failure, liver helps break down lactic acidosis, or sorry, it helps break down lactic acid. So if your liver's not working to break it down, it's going to be building up a bit more in the body. And then what's another one that we discussed that would cause your body to need more oxygen, need more energy, and due to too much demand and not enough supply would cause you to have lactic acidosis. Yes. All right, so that's all the ones I was looking for. So, and then yes, hypermetabolism. So yeah, we talked about DKA, we talked about lactic acidosis can be included with liver failure, shock, not just septic shock, but just shock in general, hypovolemic shock. Same thing because you don't have enough perfusion. Um, so even like a cardiogenic shock, like any type of shock where you're just not getting enough perfusion, not getting enough circulation going. Hypermetabolism. So we talked about thyroiditis. There's a few other ways that could happen. So it could be um, severe burns or anything like that. But don't focus on the specifics. Just getting the general idea there is going to be good. And then we guys mentioned the diarrhea and the pancreatitis. So that's very good. When it comes to metabolic acidosis, there's definitely a lot of treatments that could be done for it, and it's all going to be specific to what the origin causes. So, just from looking at all of these causes, what are some things that kind of ring out to you that could be done to try to treat it? And then we'll kind of just jot it down. So it's cause dependent. So you could say treat the underlying cause. So what are some of the ways looking at all of these that you guys can think of would help each condition, I suppose you could say. So if somebody has DKA, what is your first thought that they should be getting? Someone that has diabetic ketoacidosis, blood sugar, type 1 diabetic with a blood sugar of 500. They're super thirsty, they're peeing a lot, they're having fruity breath, vomiting. So they're gonna get it. They're gonna want insulin. What else are they gonna want? So what are your three P's? Yeah, the fluids. So the reason why they're peeing so much is because they have so much sugar in the blood. Their blood is trying to decrease how much solutes there are in the blood. So it tries to pee it out. So that's why, you can measure the glucose in the urine because your body's trying to get rid of that sugar. So for that reason, the people with really high sugar, they pee more. People that are diabetic, they pee more because their body's trying to get rid of it. So they're going to be dehydrated here. So this person here will need an for ketoacidosis, it is recommended that you do lactated ringers, and the reason why is because even though the word lactated and lactic sound the same, a lactic acid and a lactate are different. A lactate um, is going to be the lactic acid without the hydrogen anion. So it's actually a lactate is actually a bicarbonate. So lactated ringers actually has bicarbonate, which we discussed as a buffer for acid, and therefore it helps to decrease acidosis. So if you can get away with lactated ringers, the idea is that you would prefer lactated ringers for ketoacidosis. But it is also true, um, it is also true that lactated ringers is not compatible with a lot of stuff. So that it is for that reason that you see normal saline more often in general. The place where you will see lactated ringers more often will be at like L&D because a lot of the time the people, the women that are giving birth, usually they go there to give birth and they don't, not always, but most of them don't also have an underlying condition. So the main thing they're there is to give birth. So they can get lactated ringers because it's more compatible with the body, less risk of hyperchloremic acidosis over periods of time, and they don't care as much about compatibility because they're just there to give birth, and then they have IVs to um, in case they have a postpartum hemorrhage. They don't have to like, all the sometimes of course they will give antibiotics and they'll run other stuff. What? Oh. But yeah, so that's the idea. So lactated ringers is technically in general more, you could say more beneficial for the body, but it's not as compatible with certain things. So somebody in med surg that might be needing a lot of antibiotics constantly or have things that are going to be wanting to be run through their line that is that might not is probably not going to be compatible with lactated ringers, and that's why they usually default to normal saline, just so that in the scenario they can just add on something and it'll be compatible with the solution. If they're getting blood, also, you can't run lactated ringers with blood; it has to be normal saline. Um, so that's kind of the thing there. Okay, so what about um, shoot, oh, it does do that, huh? Yeah. What about for your um somebody, I mean, we kind of already talked about fluids. If somebody is in shock, they're going to get fluids. If someone's in sepsis, obviously they're going to get antibiotics. If somebody has renal failure, dialysis, or other management of that is going to be what you're going to want to do. So overall, it's just treat the underlying cause and any underlying symptomology. So hyperkalemia, for example, you're going to want to manage that. Okay. Any questions at all on anything so far? We're almost done with this, and then I'll just go over some practice questions so we can practice the interpretation of ABGs, and then as well, oh, sorry, that's the solution, and then as well as some questions, a few multiple choice questions. Okay. If not, we can move on to metabolic alkalosis. If you do have a question, just type it down. I'll get back to it. But for metabolic alkalosis, what are some causes that you guys can think of that might lead to metabolic alkalosis? Same thing, if it's here or there, we'll put it in the right spot. So don't focus on this specifically and this specifically, just whatever comes to mind for metabolic alkalosis. That's what it said. You guys are kind of understand, but yeah. So yeah, vomiting, suctioning. In terms of you guys already saw it though, but yeah, the case of base, too much antacid, so too much Tums. And then diuretics would just be from too much wasting, too much getting rid of waste, too much loss of uric acid. And then for here, if this is kind of similar to the kind of like the reverse of acidosis here, the reverse of acidosis here, in that instead you have like kind of like a vice versa, where having a low amount of potassium can cause metabolic alkalosis due to the shift. Basically, the exact same shift, just in the opposite direction. So before we had too much acid that would push the potassium out, just to balance itself out. And in this case, you have not enough potassium on the outside, so it causes a shift, uh, causes a shift of hydrogen to go into the cell, which then leads to alkalosis because now you don't have enough acid. And then just don't focus too much on like that stuff, just because it's not the very specifics of it is not something that's tested. It's just there for your knowledge. Some things that you can expect with alkalosis and acidosis is just changing electrolytes, but the potassium is going to be the most prominent one just because we know how sensitive it is. And then same idea, we're treating the underlying issue. So in this case here, and if they're getting too much antacids, you're gonna stop it. You're gonna want supplementation for potassium if they're hypokalemic. Replace the fluids because a lot of this is from loss of fluids, loss of fluids, loss of fluids, etc. Okay, so that would be the full review for the acid-base balance. Is there anything that you guys would like more clarification on before we kind of move on to doing some practice questions? And that should be pretty quick. Yes, I will give this and the document with the questions in a little bit. So let me do that right now. Okay. And it's in a doc, so if you guys want to upload it to your Google Drive and then you can make your own edits, add additional things, whatever you want, whatever changes you want to make. All right, so you guys have both of those. So let's do some of these practice questions, and I have it set up so that the answers are always down there. We can do a few of these, and then you guys can do the rest on your own. There, you'll get the general idea right away from it, and then we can focus a bit more on the multiple choice ones. Okay, so let's do this first one here. So you have a pH of 7.45. So let's kind of just do it piece by piece. 7.45. Oh, and I guess I never actually discussed how to actually read it now that I think about it, but we can do that here. We'll do one with you guys kind of go over it, and then I'll explain how I do it, which I think is the tic-tac method, I guess is what I do. But so let's just go piece by piece. So a pH of 7.45, is that normal or abnormal within the range? Like what is it? Okay, so that's normal. Okay. What about this CO2 30? Is this within range or abnormal? And if it is abnormal, is it indicative of acidosis or basic, being basic? That's low. It's more basic. What about the bicarbonate? Okay, low. So in terms of bicarb, is that considered acidic or basic? Okay. So you have this scenario where you notice that you're supposed to be matching, right? So if your pH is not considered basic or acidic, it's in a normal range, but you have abnormals with your CO2 or your bicarb. The way you want to think of it is you kind of want to split it in half. So you have that normal range of 7.35 to 7.45. So kind of think of it like whatever is on the lower half of it. So whatever is closer to 7.35 is considered acidic, and anything closer to 7.45 is considered basic. So in this case, the 7.45 is a lot closer to being abnormally basic than anything else. So we're going to consider it as basic for the terms of matching. So because you have basic, you're going to match it with basic. So you're going to match it with the CO2. Is CO2 indicative of respiratory or indicative of metabolic? It's respiratory. So we determine it's basic and we determined it's respiratory. So this would be respiratory alkalosis. Now, can anyone explain to me why we have respiratory alkalosis, but our pH is still within normal limits? Yes, we have compensation. So this would be respiratory alkalosis fully compensated We do have a partial compensation and a full compensation. This is fully compensated as evidenced by the pH being within normal limits. So when something is being compensated, you'll notice that when something is being compensated, you'll see that both the carb, both the matching value and the opposite value, and the third value, in this case, the matching value is the CO2, and the other value is the bicarb. They're both abnormal. You can kind of think of it as the the third value kind of being abnormal because you can kind of just think of it as if it's being used up to compensate. So that's why it's abnormal because it's trying to compensate. Okay. Does anyone feel like they particularly have a hard time with interpretation of ABGs? Did this one make sense? Okay. Now, there is such thing as a mixed, um, both a mixed acidosis and a mixed alkalosis. So you will have noticed here that we had the matching, but we also had, but the third value was the opposite, as in like our our CO2 was basic, but our bicarb was acidic. It is possible to have a mixed where both values actually match the pH, meaning that you're having that acidosis or alkalosis occurring multi-system wide. So you're having that issue both with your lung system as well as your metabolic kidney, liver, pancreas system at the same time. In which case you would see both the CO2 being low, signifying basic for the scenario, both, and then also the bicarb signifying being high, signifying basic. So both signifying basic. Of course, in which case your pH would not be within normal values. It would definitely be a higher number to indicate that you are having much more severe alkalosis due to it being occurring from basically two ends. But you will not be tested on the mixed ones, but just know that they exist. If you work on the floor where this is relevant, then that's something you will probably see at some point. So just know that it exists basically for now. So the next one, we have a pH of 7.12. Is 7.12 acidic or basic? Okay, so we have acidic. A PCO2 of 90, acidic or basic, high, low. Okay, so that's high. So is that no problem, Martin? So is 90 is high? Is that indicative of acidity or indicative of base for the CO2? Acidic. Okay, perfect. And then the bicarb is a 22. Is this normal, high, low? It's normal, correct. So in this case, we have pH, acidic pH, and we have a CO2 that is acidic, so we can match them. So we have a respiratory acidosis. Our pH, we can see, is an abnormal value. And our bicarb is a normal value. So that is showing no compensation. So that is evidenced by the pH not being a normal value, therefore it's not being compensated. But also by seeing that our bicarbonate is not an abnormal value. So you can again think of it like it's not being quote unquote used up. So it's not being used, therefore you're not compensating. So you would say this is no compensation. Okay. I want to do one more and then the rest we'll do on our own. So let's do number 8. Okay. So number 8, you have a pH of 7.46. Is that high or low, basic or acidic? It's going to be high and it's basic. Okay. CO2 of 26, high, low, basic, acidic. It's going to be low and basic, correct? And then our bicarb is going to be low and acidic. So let's do some matching. So we have a pH that is basic, and we have a we have a CO2 that is basic. So this is respiratory alkalosis. Okay. So what kind of compensation does this have? Um, does this have full compensation, no compensation, or partial compensation? This is a partial, so let's kind of discuss why that's the case. So we know that it's not a full compensation because our pH is abnormal, so we could remove that one entirely. So then, what determines whether something is a partial versus a no compensation is looking at that third value. So we matched the pH with the CO2. So then now to determine the compensation, we're looking at that third value. So we see that that third value is abnormal. So again, I want you to think of it like that value, that bicarb is being used up for the sake of compensation, just like when you have a patient with low blood pressure, their heart rate and their respiration rates are higher, they're abnormal because you're compensating. So I want you to think of it like that. That third value is abnormal because it's trying to compensate. It doesn't fully compensate because you see that your pH is not normal. So this is a partial compensation. There is an attempt to compensate. It has not fully compensated because the pH is still abnormal. Does that make sense? Okay, beautiful. And here I tacked on a few other things. So this PO2 is 63 and the SATO2 is 92%. So remember that the PO2 is going to be a normal range between 80 to 100. So this is someone that is showing um, alkalosis, right? Respiratory alkalosis, but their SATO2 is low. What situation do you think this could be indicative of? So we have a low decreased oxygen, but we have a low amount of CO2 being released, and we're not getting enough oxygen. Yes, so this is going to be like a very, I would say it's more indicative of like a very early asthma attack. Because like I mentioned, at the very early stage of asthma, you are initially going to be gasping for air, wheezing, hyperventilating to make up for it. Now, realistically, you're not going to see an ABG for an asthma attack that will probably show this early on because if somebody's having an asthma attack, you're not going to get an ABG, wait for the results. You're going to give them the albuterol inhaler. Maybe you'll do the ABG after, but by the time you do an ABG, you're more likely going to see the long-term consequences of having that asthma attack or having that constricted airway, which would be acidosis. But in the very, very immediate, you will technically have alkalosis because of the hyperventilation. But again, I don't think it's realistic to see an ABG that shows it because you're not going to take an ABG when this is happening. Because you're going to treat it first. Because someone has asthma, you're going to treat it with the inhaler first. And then it's more likely that they'll have the long-term consequences, which is shifting to that acidosis um, due to a long period of being mildly hypoxic or having a hard time breathing. Does that make sense? Well, I just want to watch. You're done with your session? Oh, okay. Alrighty. So then, yeah, if you guys want to do it on the rest on your own, the answers are going to be down here. And then we also have some of these here. Since I already posted both files. If you guys want to go, you guys can definitely just go and do it on your own if you want. If anybody wants to do it together, we're also free to do that. We can do it together. It's only a few. It's only 5 questions, but yeah. And then let me see if there. Yeah, does it come with rationales? No, but I think it's self-explanatory. But yeah. Is there anyone that wants to stay to do the questions together, or would you guys rather just go? It's up to you guys. I'm okay with whatever. Okay. I suppose we'll do. There's only five questions. They're pretty easy to be honest, but they're pretty simple. So we can even look at since someone say anything, we'll just go through them. Number one, this is something we've mentioned before. So somebody is getting has an NG tube. It's a getting set to suction. So what is a possible acid-base imbalance that can be caused by NG tube suctioning? So in this case, you're suctioning. The idea is that when you're doing NG2 suctioning, you're getting rid of acid. So in this case, that would be a metabolic alkalosis from excessive suctioning, okay, as well as if, well, that's the main thing there, because it's an NG tube, so it's in the stomach. So you're suctioning out of the stomach, decompress the stomach, you're also getting rid of stomach acid. So um, loss of acid, metabolic alkalosis. Okay. They have a patient with several broken ribs. That would make it hard to breathe, right? So this person is then having an issue with their breathing. They're not able to get as much oxygen in and not able to get as much carbon dioxide out because they are having a hard time breathing. So this would be respiratory acidosis due to an inadequate ventilation, ventilation meaning breathing in and out. Here's one where we have an arterial blood gas. This person has a nasal cannula. They have a pH of 7.38, so that is within normal limits, okay? They have a CO2 of 38, that is going to be within normal limits, and a bicarb of 23, so that is also going to be within normal limits. A PaO2 of 86, that is also within normal limits. So this person here uh, is having a stable is having a um, stable ABG. So what is your immediate response to this? In this case, this person here that's having the care, you would just want to monitor the person to see if there's any changes. Over time, you'll want to try to see if we can wean them off oxygen. But right now they're stable, so we'll just continue to monitor at the moment. It would only ever discontinue if you've determined it's safe to titrate down. So it would be like a titration. Maybe I could specify that they're getting 4 liters per minute. So you're not gonna go from 4 to 0. You're gonna titrate down. Maybe go to 3.5. How do they tolerate that? Go to 3. How do they tolerate that? Okay. Then you have a patient with diabetes. Blood glucose is 644. What acid-base imbalances they're at risk of? We know they're at risk of either DKA or HHNS. In this case, the idea would be that they're at risk of metabolic acidosis due to DKA. And then the last question is somebody with respiratory alkalosis has a gram-negative sepsis. So that is sepsis caused by a gram-negative strain of bacteria. Gram-negative implies bacteria rather than a virus. What would be most effective? Again, the idea is that we are treating the underlying cause. They have sepsis. Therefore, the the thing that's going to help treat the sepsis is going to be the antibiotics, right? You're going to be treating the underlying cause. In this case, they have respiratory alkalosis. In this case, I could see it being like a situation where they have kind of issues on both sides. They're they're septic, so their respirations are really high, so they're getting rid of too much CO2. But the sepsis could also lead to some like lactic acidosis issues there. So you might have a case where like it might almost balance itself out to some degree, but you'll have wacky numbers and their organs themselves might not be doing the best. But that's kind of the idea. So the core concept is treat the underlying cause. Here it's making the connection between diabetes and acid-base balance. Here it's just understanding that if someone's stable, you want to monitor. Maybe you want to slowly titrate them, but you're not gonna completely discontinue from like a 4. You're gonna titrate them down. This is a stable ABG. Just want you to recognize that. You can have acid-base imbalance not just because simply because it's hard to breathe. It's hard to actually move your chest in and out. Chest trauma. It could be a chest trauma where the patient literally cannot breathe um, in or out because this person has punctured lung. They have that kind of stuff, collapsed lung. And then here's just a reminder that NG tube suctioning can cause a loss of acid. Okay, so that is everything. Okay, so that is everything. Next week, let me see if I can show you a preview. So- All right, let's see. Let me see if I can show you a preview. So next week we have the no, this is 240, sorry. Um Renal. So we're gonna be discussing acute kidney injury and chronic kidney disease. Okay, that one's gonna be definitely a bit longer. There's a lot more pathophysiology that goes behind it, a lot of understanding of electrolytes, fluids, um, the pathology and the treatment over different stages of renal acute kidney injury and that kind of stuff. Okay, so it'll be longer. Oh, that's Kaylin.
Hello.
You guys probably seen her in lab, like, but probably when you guys were in first or second, yeah, like probably like a year ago, just because we're both busy at work. Although my job's a lot more chill than hers, so I get to do a lot of this at work.
What's this about kidney stuff?
That's for next week.
Oh shit, that's next week.
That's for 2:30. Yeah.
Oh, I'm doing two. That's fine.
Oh, you are?
Yeah.
Oh, okay.
Well, I'll figure it
Yeah, she'll figure it out. Oh, everything's already done for 2:30, so you just have to read it.
out. Okay.
All right. All right, guys. Have fun. Tomorrow you have class. I think. Actually, I don't know. I just kind of said that. I don't know. Yeah, so just take it slow. The good thing about the new curriculum now that you guys are at third semester is that it's spread out over 12 weeks as opposed to ours, which was over 9 weeks. Nine? 9 weeks. Yeah, 9 weeks. So you guys have a shorter psych and a longer med search, which is better because longer med search means more time to get stuff done. Shorter psych doesn't make a difference, to be honest, because well, it was technically like half psych and then half community, but yeah, so we'll get through this, no problem. It's a focus on clinicals for sure. Third semester, they really test you on clinical, make sure that you got all your skills down and stuff. And then when we get to psych, that's my specialty. So you guys will be just fine. I'll help you with your farm in that as well. Just from everything I see at work, things I've done my own research on. But yeah, so that's kind of how the plan is. Yeah, just get some good sleep and take it slow, but don't take your foot off the gas pedal. Don't get complacent. When you notice yourself making improvements in clinical, don't just stay at that level. Try to keep improving little things. Just because it's a journey. Even when you finish nursing school, you're still gonna be learning, so you can't ever take your foot off the pedal. You have to keep being curious, and that's how you're gonna be successful. All right. If you guys have any questions, just put it down on Pronto. I will respond at weird hours, but I will respond. And I'll see you guys later. All right.